Good afternoon, everyone. My name is Maya Luria, and I am thrilled that we get to continue on with Heart Month. Today, we're going to be talking about symptoms and tests for heart disease. I have David Strout here with me today. He is a family nurse practitioner over at Pima Heart and Vascular, and he is, specializes in cardiology. We were talking earlier, and David, about how important it is to be proactive when it comes to your cardiovascular health.
Correct.
Yeah, so I know you're going to share more about what people can learn, what kinds of symptoms they might be having, and when they might need to go see a physician for for cardiovascular disease.
Correct.
In addition, we are on YouTube as well as our Facebook page today. So when you're watching us, feel free to leave us any questions in the comments, and we'll be sure to ask those afterwards. So David, welcome, and I'll put your presentation up here for you so that you can get started.
Sounds great. Thank you. All right. Well, welcome, everybody. Appreciate you joining us today. As she said, I'm David Strout. I work with Pima Heart and Vascular for cardiology. And what we'll be talking about today is symptoms and tests for heart disease. As we mentioned a minute or two ago, it's much better to be proactive than reactive when it comes to cardiology. And knowing the symptoms and how we test and evaluate those symptoms is the best way to be proactive. Let's see. Trying to get the screen to move on here.
Hey David, go ahead and click the mouse on the presentation, and then it should go ahead and move for you. Oh, hold on. And now hit the arrow key.
There we go. Okay. I'm like, I was doing what I was told to do. All right. So symptoms. ACS, or acute coronary syndrome, is kind of the symptom that everybody thinks of when you think you're having a heart problem. It's, the one where you're clutching your chest and you're sweaty and you don't feel well. That's what everybody comes to recognize as ACS, but we'll talk in a few minutes about the other signs to look for that could be indicative of a problem with your heart vessels. We will talk about symptoms of elevated blood pressure, congestive heart failure, atrial fibrillation, which, if nothing else, the commercials on television for Eliquis and Xarelto and so forth have made atrial fibrillation a lot more known. There are other arrhythmias that we will speak about, and then peripheral venous insufficiency and lymphedema. While they are not necessarily symptoms of a heart-related problem, they do fall into this presentation with symptoms that we should talk about, as peripheral venous insufficiency and lymphedema obviously present as swelling in the legs, pain and cramping that often go along with some of the other issues that we will be speaking of. So acute coronary syndrome, or ACS, is generally chest pain that's associated with sweating, dizziness, nausea, anxiety, or fatigue. And you can have some of these, you can have all of these. And also feelings of impending doom or a feeling of extreme anxiety. If you have a history of coronary artery disease, I often tell my patients that one of the things they should be familiar with is what were the symptoms they had when they had problems before. More often than not, if they are having a similar problem, they're going to have the same type of symptoms. So I will often ask them, what type of symptoms did you have the last time you were told you had a heart attack, or the last time you needed to have a cardiac catheterization and have a stent placed? And that gives me a better idea of what testing needs to be done and whether this is the presentation of acute coronary syndrome, and the general public being aware of those symptoms that instigated the former event will help them know when they need to seek help from us as well. With hypertension or symptoms or signs of hypertensive urgency, there could be chest pain or tightness, dizziness, headaches, fatigue, flushed feelings, or blood pressure above an agreed upon value by your PCP or your cardiologist. Some of the common guidelines that we provide are a blood pressure of either 140/80 and higher consistently, or 150/90 are the two that are commonly kind of used as a guideline. But I also tell patients that they may feel the symptoms of hypertension with blood pressures that are merely 20 to 30 points above what their normal is. So if they normally run 110/60, somebody with a blood pressure of 130/80 may be symptomatic. And while it doesn't fall under what we would see in a textbook as a guideline for concerning hypertension, for them, they are symptomatic, and it is something that they should be aware of and that we need to be aware of in order to provide assistance in managing. You know, we also talk about the long-term effects of elevated blood pressures, because one may say, why do we need to know the symptoms of high blood pressure, and what is the long-term significance of managing blood pressures properly? And as you see on the screen here, you know, there are risks of having a CVA or cerebral vascular accident. There are issues with heart failure, myocardial infarction or MI or heart attack, renal or kidney failure, eye and vision problems, and brain damage, and long-term risk of dementia with untreated and unmanaged blood pressure, elevated blood pressures. We spoke of CHF earlier, which is congestive heart failure. A lot of people get very concerned when I tell them that they have some element of congestive heart failure, as for many years, until more recently, when we have very adequate ways of managing congestive heart failure, people being told they had congestive heart failure felt it was a death sentence and that their life essentially was over. And some of the symptoms of heart failure, congestive heart failure, shortness of breath, or breathing problems with activities that did not previously create breathing problems. There is edema or swelling of the extremities. It's often in the lower extremities, as it's the most distal or furthest part away from the heart, but you can also see it in the arms and torso or midsection of the body as well. Heart failure itself is often managed, as I mentioned. We have lots of ways to manage it now. There are newer medications out on the market, such as Entresto and Vercuvo, but there are the tried and true ones that we've used for a number of years now, such as diuretics like Lasix and torsemide. We often have our patients reduce their salt intake, as that can cause fluid retention in the body. And we also want them to restrict their fluids, which in Tucson, Arizona is a little difficult to recommend, because there's a fine line between keeping enough fluid off and the patient becoming dehydrated from the climate we live in. So that's actually one of the more difficult ones. I often tell my patients that I want them to try to stay hydrated, not to worry too much about fluid restriction, because it tends to get overdone. And then we can adjust their diuretics if we need to, unless obviously they're drinking liters upon liters of water a day, then we do try to restrict that a little bit. Orthopnea, which is defined as development of shortness of breath when you're lying down at night, is another symptom that we look for, which is an indicator of problems with heart failure. Or if the patient already has heart failure, it's an indicator that we are not managing their volume well enough and keeping them dry enough in order to be able to breathe at night. Risk factors of CHF include, as you can see here, coronary artery disease, or CAD, heart attack, hypertension, irregular heart rate, and diabetes. Irregular heart rate, just to touch back on that, would be especially long-term atrial fibrillation with a rapid rate, which creates a pumping dysfunction with the ventricles of the lower part of the heart, which then doesn't allow the moving of fluid well in the body and can lead to heart failure in a sense. So when speaking of heart rhythm issues, there are the ones listed here. Atrial fibrillation, some people will hear AFib. Paroxysmal atrial fibrillation, which essentially is atrial fibrillation that comes and goes and is not chronic, meaning that they're in atrial fibrillation all the time. One misconception about atrial fibrillation is that a patient cannot live in atrial fibrillation, and I have many patients that spend their whole life in atrial fibrillation. The trick to that is, as we'll talk shortly, is mitigating their risk for stroke and then managing their rate. As we spoke earlier, if their rate is too fast, then the heart is not pumping as efficiently, which can lead to heart failure. Ventricular tachycardia, which is a concern for, raises concern for sudden death, and it is often associated with CHF. One thing I wanted, to back up and talk about with atrial fibrillation is, as we spoke earlier, a lot of people know about atrial fibrillation due to commercials on television for Xarelto and Eliquis. Coumadin has been around forever, and we don't utilize Coumadin or warfarin as much anymore for atrial fibrillation management. In most cases, we can use the newer agents, and they are as safe, if not safer than utilizing Coumadin. And that's a lot of times based patient-to-patient basis, and we discuss that with our patients and in the office on follow-up appointments. But the determination of whether somebody needs to be on blood thinner for stroke prophylaxis in atrial fibrillation is based on what's called a CHAD score, CHADS score, and the points that are awarded in that score are for age greater than 65, female, congestive heart failure, hypertension, prior CVA, blood clot, whether it be a deep vein thrombosis or a pulmonary embolism, and TIA, and then vascular disease such as a prior myocardial infarction, CAD, PAD, or PVD, and then diabetes. And so when we have a patient in the office and we're wanting to talk with them about atrial fibrillation and oral anticoagulation, we use these criteria to determine their risk of stroke and whether they should be on a blood thinner or not. We move down to paroxysmal supraventricular tachycardia, or PSVT. It is a relatively harmless rhythm. It's a fast rhythm in a pathway in the upper part of the heart. The symptoms with that are often palpitations, dizziness, breathlessness. And while it is a essentially harmless rhythm, it can be quite annoying, and it can lead to syncopal episodes, which then do raise a risk for injury. Therefore, this is something that we would want to detect and then manage. And it's very easily managed with either medication approach, or we can have you see one of our electrophysiologists that can perform an ablation, which is a finite way of eliminating the rhythm. Premature atrial contractions and premature ventricular contractions. The atrial contractions, or the premature ones, are from the upper part of the heart. They are often mistaken for atrial fibrillation when the patient either senses them or they are seen on an EKG. It is very important, though, to determine the difference between PACs and atrial fibrillation, as the risk of stroke is not present with PACs, and therefore the patient would not need long-term anticoagulation. Premature ventricular contractions are from the bottom part of the heart. These are also harmless, but can be quite annoying. In some rare cases, patients having 16, 17, 18,000 of these a day may need a more in-depth workup and pharmacologic and or electrophysiology approach, as in some cases heart failure can occur as a result of improper pumping from so many preventricular contractions. We often place event monitors in the office setting. They can be worn anywhere from 24 hours to 30 days. We even have implanted loop recorders, which are small devices that are implanted under the skin in the chest. This then can last for anywhere from 3 to 5 years. The battery life on these can last, which allows for long-term monitoring and detection of arrhythmias. It helps in cases where episodes of atrial fibrillation may be few and far between, and we want to determine the long-term need for oral anticoagulation. And obviously, if we see some of these rhythms on a standard EKG in the office, the patient may not need an event monitor, but often the best way to detect these is with an event monitor when the patient is going about their daily life and can instigate these rhythms so that we're able to detect them and treat them appropriately. We move on to testing. Most people know what an EKG is. It's 12-lead EKG, gives us all areas of the heart with regards to electrical current through the heart, and allows us to detect whether there are problems with blood flow to certain areas of the heart based on changes on the EKG. We don't use the EKG as the steadfast determinant on every course of action, but they are a very good screening tool, and sometimes they're very, the problem is very obvious on the EKG, but again, we use it as part of the workup and not the only workup. An exercise treadmill tolerance test, that is where we put someone on a continuous EKG essentially in the office. We place them on a treadmill, and we steadily move the treadmill speed up as well as the incline up in order to, in a sense, stimulate exertional stress and see if there are any electrical or EKG changes during these times. For those patients that either are not able to perform a treadmill, or if on the treadmill they develop symptoms that are concerning for ACS or acute coronary syndrome, and or there are some changes on the EKG while they are on the treadmill, we then move towards a nuclear medicine stress test. There are a number of different ones. There's adenosine thallium and LexaScan, which are utilized at the hospital. We also use LexaScan at our office. And then there's also PET scan stress technology, which is about 10% more accurate than the LexaScan. So it's about 90 to 95% accurate. It's slightly less radiation, and it is the same technology utilized for people who have cancer or malignancies, or the concern for those, and we use that PET scan technology to light up just the heart muscle. And essentially with the nuclear medicine stress test and the PET scan stress test, we send out an isotope to the heart muscle and we look at what essentially lights up during rest. We then inject the patient with a medicine called adenosine, which is the same chemical our body makes when we exercise, which causes dilation of the coronary vessels. So we are essentially simulating stress. We then send the isotope back in, or inject the isotope again. And if the pictures from the rest images and the pictures from the stress images match, we then deduce anywhere from 80 to 95% accuracy that there is no significant blockage causing problems that would lead to a heart attack. If the images don't match up, then the areas that there is a mismatch, we deduce that there is significant concern that there may be a blockage to that region of the heart, and then the patient would need to undergo cardiac catheterization for a definitive diagnosis. 2D echo or cardiac sonogram or echocardiogram is an ultrasound image of the heart. It's the same technology utilized in the OBGYN setting with, looking at babies in the womb and so forth. It's sound waves that are sent out. They rebound off the object that we're looking at, come back to the sonogram probe, and they create a picture. We utilize this technology to look at heart size, heart function, valve function, and the area around the heart called the pericardium. And this allows us to determine if there are well-functioning valves or if there are any valve problems, whether it be stenosis, which is kind of arthritis in the valves, or whether it be reflux or regurgitation, which is backflow of blood across the valve into the chamber that it was pumped out of, allowing that backflow of blood, which can lead to problems down the line. Pericardial effusion, or that pericardium that we look at, is often utilized more in the inpatient setting after procedures and surgery, but we do look at that when you're in the office to ensure that there aren't any problems there. Heart function, as I spoke about, is what we look at with regards to heart failure. Normal ejection fraction, and ejection fraction is what we look at to determine heart function, is anywhere from 50 to 60%. And so anything below that is considered heart failure. We perform carotid ultrasounds in the office. Those are designed to look at the carotids that are in the side of your neck. And that is to ensure that there isn't any calcification or blockages there that could lead to stroke. Renal artery ultrasounds are very useful for us in the general cardiology world for patients that have high blood pressure that has become difficult to manage. We will often do a renal artery ultrasound to check the blood flow to the kidneys. Diminished blood flow to the kidneys or a stenosis or tightening of those renal arteries can make blood pressure management difficult. It will then allow us to either tailor-make their blood pressure treatment to that, or they may need to see somebody to have a vascular procedure to open up those renal arteries to allow for better blood flow and improved blood pressure management. Peripheral venous insufficiency studies, as I briefly touched on at the beginning, looks for reflux in the greater saphenous vein and the small saphenous vein in the legs, along with the deep vessels, the popliteal vein and femoral veins. And the greater saphenous vein and the small saphenous vein, we can actually do procedures on to rectify the situation, basically, and move the blood back to the deeper veins. In patients that have problems with swelling and cramping, varicose veins, and other issues, non-healing wounds and so forth, as a result of this venous reflux. It's a very short outpatient procedure done at our vein center. Dr. Morales, who is my collaborative physician, actually performs these procedures. And they're same-day procedures and minimal to no downtime afterwards. These studies are done by us and then followed by us. Calcium scoring is basically a CAT scan of your chest that looks for calcium in the coronary vessels, and based on how much of the coronary vessels is involved, dictates a score. 0 obviously is the best score you can get. It means there's no calcium whatsoever. And then once we get around 300 to 400, this is considered significant on the calcium scoring. And the importance of this is there are a lot of patients that have high cholesterol and high lipids and so forth, and are intolerant to statin drugs. And while there are new medications out on the market, patients are either unable to afford them, even if we, as we work through the authorization process to get them, or they don't want to take medications to begin with. And calcium scoring allows us to really determine whether or not the patient has to have their lipid panel managed. If you have somebody that's 75, 80 years old and their calcium score is 0 or even 100, their cholesterol is a little bit elevated. We really have to determine or look at, is it really necessary to manage their lipid panel? At 75 to 80 years old, they've not developed enough calcium for it or plaque in their vessels to be considered significant. And so the risk of them having further side effects from medications or, as going against what they want to do in a sense, or pushing them to treat lipid panel is maybe not necessary if their calcium score is negligible. And at the bottom there, I put in lipid panel, LFTs. These are things that we follow for patients that especially are on statin drugs, as it can affect your liver function test, which is LFTs. The lipid panel, obviously, if we're treating something, we need to follow it to see if it's working or not. CRP cardiac, I get asked about this a lot. CRP cardiac is basically an inflammatory marker, CRP is, and there's a cardiac version of it. And while it can be elevated, I've never felt that it's truly been of use to dictate a course of care in cardiology. I personally don't use it. I use all the other things we've spoken about to mitigate risk and evaluate for risk. Renal function is very important, along with electrolytes, especially in our patients being managed for heart failure, in order to determine that their kidneys are tolerating the diuretic therapy. And a number of the diuretics do deplete the body of sodium and potassium, and these need to be repleted appropriately to avoid any arrhythmia or other problems. And that is the end of my presentation. I'll put my information up there, and I'm open to any questions if anybody's there.
Thanks so much, David.
Sure.
I do have a couple of questions that came in.
Okay.
And one is really just about all the tests, right? There seems to be an abundance of them. Are there some that you give every person, like you would have a standard, or is there one that's sort of the go-to test?
Any new patient gets an EKG because I want a baseline. As we talked about earlier, we look for changes in an EKG. So if I have a patient that's been following with me for 18 months, but I don't have an initial EKG, they come in with symptoms and I do an EKG, I have nothing to compare it to. So it's always helpful to have one so that I can compare it and say, okay, this looks different. We do EKGs quite a bit. I think it's the cardiology bread and butter, just because it's a very good screening tool. If somebody says they have palpitations, an EKG will tell us if there's a rhythm issue. Patient has chest pain, it helps with that. So I think that's a test that a lot of people get. But I'm not in the habit of testing people to death. I prefer to sit down and talk with a patient and figure out, okay, why are they here to see me? What's going on? What have they already had done? That's very important to find out what they've already had done. Sometimes we have new patients that come to us after they've been at the hospital for something cardiology related. Well, if they had a bunch of the testing done at the hospital and it was adequate, me repeating all the tests 2 weeks later when they come to see me doesn't make sense either. So I really like to tailor make it, but I think an EKG, getting cholesterol levels on people is very important. And I really like to do a treadmill test in the office on a lot of patients. Because to be honest with you, a lot of people come with chest pain or something like that, or they have a family history and they're concerned about their risk. And a treadmill stress test in the office for somebody that's able to manage a treadmill is a very non-invasive, adequate screening tool.
Okay, great. Now, if you know that somebody might be at risk of cardiac arrest,
Okay.
And maybe you can sort of describe what the difference is with cardiac arrest. Are there any tests that you can perform to provide somebody with what their risks are of cardiac arrest?
Some of it, I'll be honest with you, short of me being clairvoyant, you can't. I mean, I'm not trying to be, flippant, but
Sure.
I mean, short of being clairvoyant, you're not going to know for sure. But I think getting a good history on a patient, knowing what testing they've already had done, knowing their family history of heart disease, how young was the first person that had a stent, bypassing, first like mother, father, grandparents, and so forth. What's their cholesterol level? And, if somebody has an elevated cholesterol level and they're not on a statin and they don't want to, as I spoke before, a calcium score is a non-invasive way to go, okay, well, your calcium score is 0. So your risk of having a heart-related event is a lot lower than somebody that has a calcium score of 500 or 600 or higher with elevated cholesterol. So I don't, does that answer kind of
Yeah,
in a
yeah.
way? I mean, it's, obviously good history taking is really the hallmark of it. It's just kind of getting an idea of what the patient has history wise and what their family history is. And then we're able to kind of speak on what do we think really is their risk of having an acute heart attack or a problem down the line in the near future.
Okay, so another question came in about congestive heart failure.
Okay.
Does that cause a fluid buildup around the heart?
In a sense, it can, yes. I mean, heart failure causes fluid buildup in the body. Um, Heart failure can be caused by a heart attack, can be caused by, we're actually seeing, and unfortunately, we're seeing it with people with COVID. At the hospital, we've seen some patients with COVID that then develop a weakness in the heart and then fluid buildup. Usually, the fluid buildup is not essentially around the heart in the pericardial sac around the heart, but more in the lungs and in the extremities. But it is possible to develop some fluid around the heart itself, but not as common as the other areas of the body.
Okay. And the last question that I have is there a time when heart disease has progressed so far that diet and exercise just won't help?
Yes. Yes. I mean, I often say you don't get to pick your parents. So, I mean, sometimes you have a very strong family history. You do everything you can. I actually know somebody, I do a lot of running, and I know somebody that's a runner that she's rail thin. You would think that there's no way she has elevated cholesterol, and she's on 3 different medications and still eats well and has the worst cholesterol you could think of. It sometimes it is what it is, but I will say there are lots of things you can do that will definitely mitigate your risk. If you're smoking, stop smoking. Everybody focuses on the lungs, but smoking is one of the leading causes of heart disease, carotid disease, and everything else. Um, do everything you can, because the things you can change those things, and then we'll work on the rest.
Excellent. Okay. So if somebody was interested in an appointment, I am going to go ahead and put your information up here, David. I've got the phone number for Pima Heart and Vascular. It's
Hopefully they
520.
still, I was going to say, hopefully they still want an appointment after hearing me talk.
So 520-696-4780. And that is, I believe, to your office
It is.
over at Pima Heart. You are located, you have 2 offices, I know you mentioned.
3. I have 3.
3. Okay. So if you
So,
just let us know where those were as well.
yeah, so Tucson Heart Center is at 2404 East River Road. That's Campbell and River near El Corral and P.F. Chang's, that area. There's the West Side office, which is right behind St. Mary's Hospital. And then Green Valley office is right next to Santa Cruz Regional Health Center in Green Valley.
Okay. Well, great. I want to thank you so much for being here today
Thank you.
and
It was my
sharing
pleasure.
all things heart.
Yeah.
And We look forward to we have another presentation that'll be coming up next week. And that will be Heart Health Moving Makes the Difference. It'll be on Thursday, February 24th at 2 p.m. We hope to see everyone back then. And thank you again for being here, David.
You're welcome. It was my pleasure. Thank you very much.